Let me ask you something that I want you to sit with for a moment. What if I told you that a significant number of people who have had a heart attack, real, documented, measurable cardiac events that show up years later on an electrocardiogram, never knew it was happening? Not because they were unconscious, not because they were asleep, but because the symptoms they experienced were so far from what they expected a heart attack to feel like that their brain did not register it as an emergency. A little indigestion, some unusual fatigue, a jaw that ached for a few days that they attributed to tension, and then it passed. And they went on with their lives, not knowing that a portion of their heart muscle had just been permanently damaged. These are called silent myocardial infarctions, and they are not rare. Research published in the Journal of the American Medical Association found that silent myocardial infarctions account for approximately 45% of all heart attacks, nearly half, and they are significantly more common in adults over 60, for reasons I am going to explain in detail today, and more common in women than in men, which is a disparity that has cost an enormous number of lives, because the medical literature spent decades describing a presentation of heart attack that reflected the male experience almost exclusively. Today, I want to walk you through 5 of the most commonly missed signs of a cardiac event in adults over 60. I want to explain the physiology behind why these signs occur, because understanding why your body produces them changes how seriously you take them. And I want to give you a clear picture of when these symptoms, individually and in combination, warrant immediate medical evaluation. This is not a video designed to make you anxious about every twinge and ache. It is a video designed to close a specific gap in pattern recognition that costs lives, including, possibly, the life of someone watching this right now. So let us start with the biology, and then we will go through the 5 signs one by one. The classical presentation of a heart attack, the one that most people carry in their mental model, is a crushing, vice-like chest pain that radiates down the left arm, accompanied by sweating, shortness of breath, and a sense of impending doom. This presentation exists. It is real. It is well documented, and it is the presentation that emergency medicine built its response protocols around. But it is not the only presentation. And in adults over 60, it may not even be the most common one. Here is why. As we age, the autonomic nervous system, the network that governs the body's automatic responses, including the pain signaling that accompanies cardiac ischemia, becomes less efficient. The nerve fibers that transmit pain signals from the heart to the brain undergo a process called peripheral neuropathy that is analogous in some ways to the diabetic neuropathy that causes loss of sensation in the feet. The heart can be experiencing genuine ischemia, genuine oxygen deprivation to cardiac muscle, and the pain signal that should reach conscious awareness is attenuated, muffled, or translated into something the brain interprets as a different kind of discomfort entirely. Additionally, adults over 60 are more likely to have had previous subclinical ischemic events that have, paradoxically, provided a degree of ischemic preconditioning, a phenomenon where repeated mild ischemia blunts the intensity of the pain response to subsequent events. The body adapts, and in this case, the adaptation is genuinely dangerous because it removes the warning system. There is also a hormonal dimension, particularly for women. Estrogen has a protective effect on cardiac pain signaling pathways. As estrogen declines after menopause, this protective modulation of pain signaling changes, but not in a way that makes pain more intense. Rather, it changes the quality and distribution of how cardiac pain is perceived, making it more likely to manifest in atypical locations and as atypical sensations. With that foundation in place, let us talk about the 5 signs. The first sign is unexplained, unusual fatigue. Not the fatigue of a long day or a poor night's sleep. A specific quality of fatigue that is disproportionate to your activity level. Fatigue that arrives without obvious cause and persists without the usual resolution that rest provides. When a portion of the heart muscle is ischemic, when it is receiving insufficient blood flow, The heart must work harder to maintain adequate cardiac output. The compensatory mechanisms that allow the heart to do this, increased heart rate, increased contractile force in the remaining healthy muscle, are metabolically expensive. The body prioritizes cardiac function by redirecting resources away from other systems. Skeletal muscle perfusion decreases. The brain receives the message, neurologically and hormonally, that the body is under significant physiological stress. The result is a profound fatigue that feels qualitatively different from ordinary tiredness. Patients who have experienced this and later had the event confirmed on imaging consistently describe it as a fatigue that went all the way through. Not a surface tiredness, but something deeper. Something that felt almost like the body was conserving everything it had for a task they could not identify. This fatigue may precede the acute event by hours or days. Research has shown that in women experiencing myocardial infarction, unusual fatigue was the most commonly reported prodromal symptom, appearing in studies as the presenting complaint in over 70% of cases, often beginning days before any other sign emerged. If you are over 60 and you experience a fatigue that is genuinely unusual in its quality, not explained by your recent activity, sleep, or other known factors, and it persists for more than 24 hours, treat it as a signal worth investigating, not an inconvenience worth resting through. The second sign is discomfort, pressure, or pain in locations that have nothing obvious to do with the heart. The jaw, the neck, the upper back between the shoulder blades, the right arm, the upper abdomen, a deep, persistent discomfort that feels like indigestion that will not resolve with antacids. Sometimes just pressure in both shoulders simultaneously, like a weight settling across the upper body. The reason these locations are involved requires understanding referred pain. The heart and many of these regions share sensory nerve pathways. When pain signals from the ischemic heart travel up the spinal cord, they converge on the same neurons that carry sensory information from the jaw, neck, shoulders, and upper abdomen. The brain, which receives the signal but cannot always identify its precise origin, interprets it as coming from the familiar location rather than the heart. It refers the pain outward. The jaw is the sign I find most consistently underestimated by patients. I have seen people spend 2 days managing what they believed was dental pain or jaw tension, taking ibuprofen, applying heat, considering calling their dentist, while experiencing an evolving cardiac event. The jaw discomfort associated with cardiac ischemia has specific qualities worth knowing. It tends to be bilateral rather than affecting just one side. It does not typically localize to a specific tooth. It often has a deep, dull, aching quality rather than the sharp or throbbing character of dental pain. And critically, it does not worsen when you chew or apply pressure to the teeth. Upper abdominal discomfort is the other sign in this category that causes the most dangerous delays. The inferior wall of the heart, the portion closest to the diaphragm and abdominal organs, when ischemic, produces pain that the brain consistently refers to the upper abdomen and sometimes to the back. It feels like severe heartburn. It feels like an upset stomach that is worse than usual. It feels like something heavy sitting in the upper abdomen that antacids are not touching. I have had patients tell me they spent 2 hours taking Gaviscon before calling an ambulance. 2 hours. In an evolving myocardial infarction, the clinical rule I give patients is this: any unusual discomfort above the navel and below the chin that you cannot immediately and confidently explain, that does not resolve within 15 to 20 minutes, and that is accompanied by any other symptom from this list, should be evaluated urgently. Not tomorrow, not after you see how it goes. Urgently. The third sign is breathlessness that arrives without exertion. Not the breathlessness of climbing stairs or walking quickly. That is physiologically normal. The breathlessness I am describing is the kind that arrives when you are doing very little. Standing in the kitchen, sitting in a chair, lying in bed and finding that lying flat makes it slightly worse, and propping yourself up relieves it slightly. When cardiac ischemia compromises the pumping function of the left ventricle, the chamber responsible for driving oxygenated blood out to the body, pressure begins to build in the pulmonary circulation. The lungs, which receive blood from the right side of the heart and oxygenate it before sending it to the left, become mildly congested. Fluid begins to shift into the interstitial spaces of the lung tissue. The lungs become slightly stiffer, slightly less compliant, and the drive to breathe more rapidly intensifies. The brain registers this not always as pain, but as a vague, uncomfortable sense of being unable to get enough air, of breathing just slightly harder than the situation warrants, of a tightness across the chest that is present even at rest, and that makes a full, satisfying, deep breath difficult to achieve. In older adults, this can be gradual enough in its onset that it is attributed to deconditioning, to mild anxiety, to a respiratory virus that is taking time to clear. The key distinguishing feature is its temporal relationship to other symptoms, and whether it is new. Breathlessness that is new, that arrives without an obvious respiratory explanation, and that is accompanied by fatigue, unusual chest or upper body discomfort, or any of the other signs in this list, is a combination that warrants emergency evaluation. The fourth sign is lightheadedness, dizziness, or an episode of near fainting. The heart's primary job is to maintain adequate perfusion pressure to the brain. When cardiac output falls, as it does when ischemia compromises left ventricular function, the brain is among the first organs to register the drop in blood supply. The result is dizziness, a sudden sense of the room shifting slightly, the feeling of standing up too fast, but without having stood up. In some cases, a brief loss of consciousness or near consciousness that resolves spontaneously. This sign is particularly dangerous because it is so often attributed to other causes: blood pressure medication, dehydration, standing up too quickly, not eating enough that day. All of these are legitimate causes of dizziness in older adults. And that legitimacy is exactly what makes cardiac ischemia so easy to dismiss when it produces the same symptom. The features that distinguish cardiac dizziness from these other causes, imperfectly but usefully, are several. It tends not to be clearly positional in the way that orthostatic hypotension is. It often accompanies other symptoms rather than occurring in complete isolation. It may be associated with an awareness of the heart beating unusually, not necessarily fast, but perhaps irregularly, or with a heaviness or pounding quality that is different from baseline. And it does not resolve quickly with sitting, drinking water, or eating something, the standard maneuvers that address the more benign causes. A patient I will call Margaret came to me at 67, referred after an episode that she had described to her GP as a funny turn in the supermarket. She had felt suddenly very dizzy, had held on to the shopping trolley for support, and had felt, she said, as though the lights had dimmed for a moment, not fainted, but close. She had also felt nauseous and very tired. It had passed in about 2 minutes. She had told her husband that evening, and they had agreed it was probably low blood sugar, as she had not eaten since breakfast. Her ECG showed changes consistent with a previous inferior wall myocardial infarction. She had no recollection of any event that matched what she expected a heart attack to feel like. The episode in the supermarket was likely a manifestation of arrhythmia secondary to the ischemic damage. She had driven herself home. She had had soup. She had gone to bed. I tell her story not to frighten you, but because it is not unusual, and because the outcome for Margaret, who was diagnosed, treated, and has done very well, could have been significantly different if the dizziness had not prompted her GP referral. The fifth sign is a new and unusual pattern of sleep disruption, particularly waking in the early hours with a vague sense of discomfort or unease. This is the least well-known sign in this list, and the one most consistently dismissed as anxiety, stress, or simply the sleep changes of getting older. Cardiac ischemia does not always present as a dramatic acute event. In many older adults, it manifests as a chronic or subacute process. intermittent periods of reduced coronary blood flow that cause low-grade, recurring symptoms that come and go. During sleep, the body's fluid distribution changes. Lying flat increases venous return to the heart, raising cardiac preload. For a heart with compromised ischemic reserve, this additional demand can trigger episodes of mild ischemia that interrupt sleep, not with chest-clutching pain, but with a vague, uncomfortable waking. A sense that something is not right, that the person cannot specifically identify. Sometimes a brief awareness of the heart beating, sometimes mild sweating, sometimes a low-grade nausea. They get up, they drink some water, they sit in the quiet of the kitchen for a while, and then they go back to bed. This pattern, recurring early morning waking with non-specific discomfort that resolves with sitting up, particularly when it has emerged in the last few weeks and was not a previous pattern, should not be attributed to stress without a cardiac evaluation first. The combination of positional relief, the 3 to 4 a.m. timing that corresponds to a natural dip in nocturnal blood pressure, followed by an early morning cortisol surge that increases cardiac demand, and the vague quality of the discomfort are together a pattern worth taking seriously. Let me close with the clinical framework I use when thinking about these signs in adults over 60, because I want you to leave today not with anxiety, but with a practical decision tree that serves you. A single symptom from this list, appearing once, resolving completely, with no recurrence and no other accompanying features, note it, monitor. Mention it at your next medical appointment. It is worth recording but does not necessarily warrant emergency action if it is entirely isolated. Any two symptoms from this list occurring together, fatigue and breathlessness, dizziness and jaw discomfort, unusual upper abdominal pressure and fatigue, regardless of how mild they are, regardless of how confidently you can construct an alternative explanation, seek evaluation that day. Not tomorrow, that day. Any symptom from this list that is severe, that does not resolve within 15 to 20 minutes, or that is accompanied by a sense that something is genuinely wrong, call emergency services immediately. Do not drive yourself. Do not wait to see if it improves. Do not take antacids and lie down. In a heart attack, time is muscle. Every minute of ongoing ischemia is cardiac muscle that is dying. The interventions that save that muscle, percutaneous coronary intervention, thrombolysis, are time-dependent in their efficacy. The difference between calling immediately and calling an hour later can be the difference between a full recovery and permanent significant cardiac impairment. Your instincts about your own body deserve to be taken seriously. If something feels wrong and you cannot explain it, and it fits any part of what I have described today, act on that instinct. The downside of acting on a false alarm is a few hours in an emergency department and a clean ECG that you leave feeling slightly embarrassed about. The downside of not acting on a real one is a conversation I have had too many times with families who wish their person had gone in when they first noticed something unusual 3 days earlier. Know these signs. Share this video with someone over 60 who you love. And please, if anything I have described today rings a bell with something you have been dismissing, take it seriously tonight. I am Dr. Julian Cross. Look after your hearts, and I will see you in the next one.